Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jacqueline Meredith. This episode features perspectives on ART safety and tolerability in transgender individuals. During this podcast, Dr. Jill Blumenthal and Dr. Jennifer Cocohoba share how they manage possible ARV-associated toxicities in transgender individuals. For more information about Dr. Blumenthal and Dr. Cocohoba, and for a link to the full online educational program, including downloadable slides, please visit the link in the show notes for this episode. Now let's get started and hear what they have to say about this topic.
Hello, everybody. I'm Jen Cocohoba. My pronouns are she, her, hers, and I'm from the University of California at San Francisco School of Pharmacy.
Hi, I'm Jill Blumenthal. I use she, her pronouns, and I'm from the University of California, San Diego, Department of Medicine.
As we start to compile gender-affirming hormone therapy, treatments for HIV, comorbidities, we really start to worry about polypharmacy. And when I think about polypharmacy, one of the first things that comes to mind is drug interactions. It can get really complicated. I think we have to think about what the gender-affirming hormone therapies might be doing to some of the other co-medications, and also thinking about what co-medications might be doing to the gender-affirming hormone therapy. It does bear to mention another thing that patients often worry about is whether or not their HIV treatment is going to impact their hormone therapy. Lucky for us, we don't have to worry that much about the impact of antiretrovirals on gender-affirming hormone therapy, with a few small exceptions. So I think kind of the big takeaway points, if you have a trans person who's on hormone therapies and also with HIV on antiretrovirals, most of them don't interact with HIV antiretrovirals, although, you do have to double check a couple of them. It never hurts to run a drug-drug interaction screen just to make sure that there aren't any of those antiretrovirals in there that do have potential. We think about kind of those boosted PIs, some of the non-nucleosides like efavirenz, etravirine, nevirapine. It never hurts to take that 2 seconds to run that extra check. And new data is emerging all the time. Oftentimes, some of the new data is actually coming out in PrEP studies. So we're looking at antiretrovirals that are being studied for PrEP, but we also have the benefit of them being studied with gender-affirming hormone therapies. And so we're seeing things like, at least in the PrEP data, no clinically significant bidirectional effects being found with tenofovir disoproxil fumarate, emtricitabine, and different hormone therapies, or no interactions being observed with cabotegravir, long-acting, and gender-affirming hormone therapies. These data, I think, are reassuring, but we can always use more. So we really do need additional data and people to keep doing these studies to ensure that medications are not having an impact on gender-affirming hormone therapy. And one example is the ACTG study, the 5403, which is really looking at the estradiol concentrations between antiretroviral regimens that are boosted versus unboosted. So studies like this are going to continue to give us even more data, hopefully more reassuring data, about the interactions between antiretrovirals and gender-affirming hormone therapy.
Thanks. That was really such a great summary and really helpful when you're thinking about the patient in front of you and their concerns. And I do often think about what matters most to them. And in addition to, will my hormones work? I think there are a lot of issues that come up with transgender individuals, and something that obviously came up for that first patient, which is weight gain. And we know that there are antiretroviral medications, including our instis and tenofovir alafenamide, that may be associated with weight gain. And then on the flip side, the gender-affirming care we know can cause weight redistribution, changes in muscle mass. And for some patients, that may be welcome, but for some patients, that might not be what they desire. We know that regardless, estrogens can cause weight gain. And what do you do with that information when a patient is coming to you with the concern of weight gain? The other thing that we always have to take into consideration with any patient, but we know for transgender individuals that may have a lot on their plate and are dealing with a lot of psychosocial issues, are the life stressors and what's going on with someone. And while it could just be the medications, there may be more going on. And that's something that we always have to think about as clinicians.
There's so many factors.
Right. So some of the things I think about when this is a chief concern of someone, there's always should we switch your ART? Right now, the current guidelines do not suggest doing that. But you could consider switching to an NNRTI-based regimen. This has to be very patient-centered and discussed what the pros and cons are, and essentially saying we still have gaps in knowledge in this area. But there are patients who ultimately want to choose that. The other possibility is to reduce the estrogen dose. That would depend on a lot of factors. In this particular person, I mentioned that their dose was maybe a little bit on the higher side, so maybe coming off the estrogen could help somewhat. And of course, we always have to stress lifestyle changes. What is this person doing for diet and exercise? Is it something that they've been able to focus on? And then the other consideration is if they're diabetic or pre-diabetic with comorbidities, that a GLP-1 agonist can be considered, which is becoming a more and more frequently used medication in our patients living with HIV. So then the other thing to consider is cardiovascular risk in transgender individuals. And I think sometimes there's an overlap between weight gain and cardiovascular risk, but I think these things actually need to be teased out a little bit more and thought about differently. We know with HIV itself, the actual virus, with viremia, we know that can lead to inflammation, which may increase cardiovascular risk in transgender individuals. We also know that there's certain ARVs that have been known to increase cardiovascular risk. PIs as protease inhibitors are one of the main categories. Bacavir, we went back and forth on for many years. Fortunately, it's not a medication that we use as much anymore. And now, there's some question around whether the INSTIs also could have some cardiovascular risk. And I think more data needs to come from that. And then again, in terms of the actual gender-affirming hormones, we know that there is increased venous thromboembolic risk in transgender individuals taking estrogen. And especially as they get older, that becomes, really important consideration. And the estrogen may also increase risk for hypertension, dyslipidemias, and stroke. Most of this data that we have, though, is from cisgender women, and we really need to know more about this in the trans populations. But it's something that we definitely have to keep in mind, particularly as patients age. And then again, I said it about the weight gain, life stressors absolutely have an effect on cardiovascular risk, and always something that needs to be discussed with patients. So some of the strategies I think about, I would consider avoiding the PIs, except maybe atazanavir and possibly abacavir. And then we always have to think about the impact of TAF in patients with hyperlipidemia. And that's something really to consider. And I don't know about you, but I still like to use TAF when I can. It's really in the rare exception where I would really think about removing that. I think one of the other big things I think about is instead of using pills for estrogen, I like to switch to injectables or patches when people are above the age of 40 to lower that risk of thromboembolic disease. And then, of course, the biggest thing is, if someone is smoking, how can we work on smoking cessation? What does that look like for the person? And of course, there are other medical issues. I don't want to give them short shrift, but just quickly to talk about bone health. We know that, there are some ARVs that may increase the risk for osteoporosis with tenofovir disoproxil fumarate. And that goes for everyone, but then for transgender women, they may be at increased risk for osteoporosis. One of the big risk factors is not using hormones after gonadectomy when there's sort of insufficient estrogen around. And then with renal impairment, again, we know that there are ARVs that can increase the risk with tenofovir disoproxil fumarate. And we know that when people take hormones, there can be changes in their body composition and lean body mass that actually can impact their creatinine levels and what the creatinine function is. So some strategies to consider for both bone health and renal impairment issues, easily can switch from tenofovir disoproxil fumarate to tenofovir alafenamide. And then, always want to highlight the importance of exercise and the use of light weights, particularly for bone health. And then for renal impairment, instead of using the creatinine clearance when an ideal body weight right from the start, what we are doing more is using that after the patient has been on hormone therapy for about 6 months, because that will then there'll be some changes to the lean body mass and the body composition that you can use in your calculation. And then using their gender identity is actually more appropriate for that calculation, which I know that the EMR may not do, and it might be something that you have to do yourself.
As Jack, exactly what I was going to say is, it's something we have to be really conscious about, because I think a lot of us from muscle memory kind of take at face value what's in the EMR, and we have to remember, oh, wait, maybe I should do this a different way.
Right.
Thank you, Dr. Blumenthal, for bringing up all of those really important issues that really outline the intersection between, some of the key issues in the intersection between caring for transgender persons and persons that are living with HIV.
I always like to think about, or I remind myself that often patients will prioritize their gender-affirming hormone therapy over their ARVs. However, we know that accessing gender-affirming care can be really challenging, and insurance issues are pervasive. We know that the Ryan White formulary just started covering some gender-affirming hormone therapy, but it's relatively basic. And I don't believe right now patches are on there. I hope that one day they will be. But making changes that a patient is actually able to do that their insurance will allow is obviously really important. I always tell patients, let's try to do this and then see what we can get done. And then, there's nothing better than having pharmacy support. Dr. Cocohoba, you're just incredible with what you do. And I think places that don't have pharmacists who really know what they're talking about, it can be challenging. And I think that making sure, if you don't have the luxury of working closely with a pharmacist, finding a local pharmacy where you can talk to someone about, what you need to do and making them your specialty care pharmacy for patients, I think is really important.
I think thank you so much for saying that. I think it begs the question or makes us really think about how team-based care can really support, transgender persons with HIV. And I think I feel really spoiled that I work in a clinic with providers that are willing to do both. They're supportive of patients' gender-affirming hormone therapies. If they reach a limit where they feel like they're beyond their expertise, they'll reach out for consult, but they're willing to kind of do what they can in the clinic there. And I think it behooves our patients as well, the idea, the mystical idea of the one-stop shop, right? Where they can get all of the different pieces of them cared for, really helps create that sense of medical home or, patient-centered care. And I think you probably practice in a place that's very much the same.
Yeah. And so when I think about the team approach, I also think about combining things as much as possible. So when I think about, drug formulations, combining things for patients, may work really well. So people who, are already on oral ARVs, oral estradiol, or, other oral therapies may be easiest for them because they're already taking, an oral medication. However, now with our new long-acting injectable cabotegravir and rilpivirine, that may be really appealing for people who are injecting estrogen or testosterone, which is very exciting. If they have no other pills, maybe this is all they're doing and they don't have to worry about the day-to-day pill taking. I do want to remind people that we have to be cautious about people with gluteal implants and not injecting in those areas for those individuals. And then, of course, we can't talk about challenges to adherence without bringing up the psychosocial barriers that a lot of patients face. Things that we would like them to do, or, can you come back in a couple of weeks to recheck your labs, or, let's reweigh you. If a patient doesn't have transportation or they're not housed, or they're just trying to figure out how to make ends meet, coming back may not work so well. And we always have to keep that in mind. And then, unfortunately, stigma is still very prevalent. And while we have tons of patients that live really out and proud with their HIV and being transgender, There's some that don't. And, and I think of them having to face, there are a lot of different kinds of stigma, but particularly in this area, both related to HIV and transgender and being transgender. So just things to keep in mind as you are, with the patient that's sitting in front of you.
Absolutely. I think it just brings back hits home the idea that, if at all possible, a team-based approach really works, integrating all the disciplines, nursing, medicine, pharmacy, social work, case management, et cetera. So we can really provide a place where transgender persons with HIV feel like they are able to get all of their needs met by the team that cares for them.
Agreed. I think this was really great. And we just wanted to, summarize some of the key points that we hope to make, or that we hope to have made today. Very importantly, most gender-affirming hormone therapy medications don't interact with antiretroviral medications, but we have to remain vigilant, like we should for most things, especially for certain ARV medications. Fortunately, the ones that we use most commonly aren't really of high concern. And then we also have to consider the impact of other medications, including ARVs, but just other medications that we use on the drug concentrations of estrogen and testosterone. And important to run DDIs if you need to, or ask a pharmacist for help if you need. When talking about the potential ARV-related toxicities like weight gain, cardiovascular disease, we should also think about the gender-affirming care, gender-affirming hormone therapy, what's the impact on that? And then other non-medication risk factors and things that we can do to address those outside of it. And then finally, we talked about the barriers to ART adherence and really retention for transgender individuals, and working as, in a team-based setting to help patients be able to address a multitude of needs that may help them. But we also know that helping patients access gender-affirming care actually may help them continue to take their ARV medications. So really combining those two can be critical and is an excellent approach if it's something that you're able to do.
So I want to thank you all for joining us today. I encourage you to go online for more CCO content on ART safety and tolerability.
Thank you very much to Dr. Blumenthal and Dr. Cocohoba, and thank you to our listeners for joining in. As a reminder, to view the full state-of-the-art, applying up-to-date safety and tolerability data to individualized HIV care program on the Clinical Care Option website, click on the link in the show notes for this episode. And please be sure to check back for more episodes on important infectious disease topics. Thank you.